Good morning, everyone, and welcome to our International Colorectal Web Meeting. Today, we have pediatric surgeons joining from Malaysia, Yemen, Mexico, Bangladesh, Spain, Vietnam, Brazil, Iraq, Libya, Czech Republic, Romania, Turkey, United States, and Japan. If I have missed your country, please type in the chat, and I'm going to sure acknowledge at the end of the meeting. So the first presenter today is Dr. Ana Cristina Castellanos. She's presenting from Instituto Nacional de Pediatría in Mexico City. So welcome, Dr. Castellano.
Thank you, Dr. Andrea. Okay. Could you see my description?
Yes, but we're seeing your presenter notes on the right-hand side.
Okay, just wait a minute.
Perfect.
It's okay right now?
Perfect,
Okay.
yes.
Hi, so it's a pleasure to be here with you. I'm going to present our first case. Okay, so the case of this day is a 5 days old baby girl. In the third trimester ultrasound, the mother was identified with a coccygeal mass. So, due to this finding, the obstetrician opted for a C-section. Okay. Ahí está. At birth, the patient showed minimal respiratory effort and required 3 cycles of positive pressure ventilation followed by CPAP support. A sacrococcygeal mass was immediately evident. On the 5th day of life, once the patient was stable, she was referred to our hospital for further management. On physical examination, we found a predominantly cystic, soft, tense, vascularized, and apparently painless mass in the coccygeal region, measuring 14 by 11 centimeters. The anus was patent and located in the center of the mass. These are some pictures of the patient. We initiate the diagnostic workup with basic labs and tumor markers. All results were within normal limits, except for an elevated alpha-fetoprotein level. We ask for a contrast-enhanced abdominopelvic CT scan, where it reveals a heterogeneous, predominantly cystic mass originating from the coccyx, with densities around 10 Hornfels units, signs of vascularity, microcalcification, and arterial phase enhancement. The tumor measured approximately 10 by 10 centimeters with no evidence of intrapelvic or intramedullary extension. I will put. So, based on these findings, we diagnosed a sacrococcygeal teratoma, Altman type 1. We proceed with surgical resection of the tumor, coccyectomy, and flap reconstruction. Also, we'll place a central venous catheter. Here is a brief video about the surgical procedure. The surgical specimen weighing 716 grams and the measuring was 10 by 10 by 9 centimeters. In the postoperative management, we include parenteral nutrition, antibiotics, and loperamide twice daily. By the postoperative day 4, the patient had stable progress. The enteral feeding was started on day 6, and the Penrose drain was removed. The urinary catheter was withdrawn on day 7, and loperamide was maintained only daily, and rectal irrigation were initiated. Then we have the histopathology report, and it was mixed health tumor. The 70% was a mature teratoma and 30% gall sac tumor. Given to this result, the oncology team completed staging studies with a CT scan of the chest and a PET scan. Okay. The chest CT scan showed no pulmonary metastasis, as you can see in the CT. And we asked also for a PET scan where that was negative for distant metastasis. Also, we have serial alpha-fetoprotein levels that progressively decrease to age-appropriate ranges. After multidisciplinary discussion, it was decided to continue close surveillance without adjuvant chemotherapy, and that these are also postoperative images that we capture. This is also a graph that shows the trend of decreasing of alpha-fetoprotein levels, which is a crucial marker in surveillance, and raising levels may indicate recurrence. At the most recent follow-up, the patient is on mixed enteral feeding with spontaneous bowel movements and appropriate gain of weight. Rectal dilations with Hagar number 12 have been performed without complications, and the surgical ones shows adequate healing. In the final assessment of it would be important to evaluate fecal continence as the patient grows to determine if the patient needs supportive measures such as enema. So we want to share with you this type of case because we believe that this type of procedure should be used in such cases as the conventional chevron incision approach causes an rectal displacement, as you can see in the image of the left, resulting in an obstructive angle. Thank you.
Thank you very much, Dr. Castellanos. Today we have a special guest. I invited Dr. Chris Derderian, who is the fetal surgeon at Children's Hospital Colorado, and he does all the sacrococcygeal teratomas in our hospital to comment on the case. And there are a lot of questions, so I'll let him comment, and then we'll go over the questions later. Congratulations on the beautiful case. Dr. Derderian.
Thanks for inviting me. I don't know if I'd call myself a special guest, but I appreciate it. Great case. Thanks for sharing it. I was actually really impressed with your incision. We've gone back and forth multiple times on trying to find the right approach for displacement, for healing. And so I think these were really, your pictures were great to see the accurate placement of that anal sphincter. So that was great. To comment on these, we see a fair number of these a year, probably 5 or 6 a year. We really worry, we think about these from different perspectives. In utero, we certainly worry about high drops. This was not particularly vascular, but we keep a really close eye on these in utero for development of high output cardiac failure, high drops. In doing so, these can grow rapidly in the 3rd trimester. It usually has to do with receptors on them, like insulin-like growth receptor factors and VEGF receptors on these cells. So you can get rapid growth in the 3rd trimester. Interestingly, you're not just measuring the sacral coccygeal teratoma ratio, but also echoes are critical because we're looking at the combined cardiac output, and we really start to worry about that when it becomes in the 600 to 700 range. So oftentimes we will dictate the time of delivery for those if we're worried about that. Sometimes we'll even do an exit to resection for kind of hemodynamic stability during the resection for those. When you think about these postnatally, I really liked your operative pictures because I think one of there are, in my mind, a couple really important key points in the operation. One is preserving that rectum, so using that Hagar dilator there so you can really identify the rectum and make sure you don't injure it during the dissection. And two, those gluteal muscles are really splayed up on those tumors, and so you have to find the perfect plane to get between the tumor itself without getting into it and preserve that so that you have that kind of cushion as they grow. And then obviously you're taking the coccyx as well during those cases. And then the last thing, you showed that I think is worth noting is surveillance for these. I would say that even though you had a yolk sac component, we typically don't get a PET scan. I'm interested if that's other people's practice or not, but surveillance is really important for these. We say physical exam and AFPs. We generally watch those every 3 months, monitoring for them to significantly reduce. We use that 1980s normogram that was developed to show exactly where we should be throughout each age postnatally, but you're really looking for normalization within the year. And then, if you think about the recurrence rate is highest within the first 3 years. So we keep a really close eye on them for the first 3 years of life and then kind of spread out surveillance. We have added MRIs into our surveillance program. That's not generally been widely accepted around the country or internationally yet, but we have implemented MRI, and that most people will just do physical exam and AFPs every 3 months for 3 years at least. So those are my thoughts. Great case though.
Thank you very much, Dr. Derderian. There are a few questions. I think some for Dr. Castellanos, some for Dr. Derderian. So one is the one that Dr. Derderian mentioned, PET scan. The question is, why PET scan at this age?
We wait that an Altman type 1 always, most of the cases are a mature teratoma. And because of this girl has a mixed tumor, gel tumor, that's why, and because she was a little baby, the oncology team decided to, at the beginning, they think, okay, she's going to get chemotherapy. But then they thought that maybe it would be to make more studies and then with that decide if she is going to chemotherapy or not. So they thinking in a York cell tumor or immature teratoma, they decide to look for other sites where maybe the girl has metastasis, and because she didn't have any metastasis, they say, okay, we are going to just surveillance and have a close like monitoring of the alpha fetoprotein levels and things like that, and don't give her chemotherapy. But it was because the histopathology.
Okay. The other question was, what was the indication for anal dilation? Was the sizing abnormal before the resection? Were you concerned about anal stenosis or colonic stenosis?
No, the girl has a normal anus, but just because in other type of procedure, of surgical procedure, you can have like the ankle and make a stenosis. We just like try to emphasize this just to know for everyone that we don't, with that type of procedure we don't have like stenosis. But it
Perfect.
was for that time.
And the other question, I think it was already mentioned, yes, the coccyx was excised. And now a question for Dr. Derderian. When do you advise pre-op embolization or proximal aortic control for bleeding?
That's a hard question. We, fortunately, we haven't seen many cases where we've had to do that. I think there's been one case that I can recall where we've gone in laparoscopically and clipped that branch off the middle sacral. I think it has to do with what the imaging looks like. We get MRIs preoperatively. And if there's any safety concern, that's the approach we've taken. But again, it's extremely rare. I think something that's more controversial than that is people have really worried about these large vessels that are promoting growth for these tumors in utero. And so we've talked about different modalities of trying to get control. It's generally accepted that if these babies develop hydrops before 27 weeks, that we'll do an open fetal resection of these. But there's a lot of conversation about using heat devices such as lasers or RFAs to ablate that feeding vessel into them in utero. And the problem we've seen with this from various reports around the country are you can get, once you've ablated that vessel, you get a necrosis within the tumor itself, and then it can bleed into that necrotic tissue. You can also, with the RFA, you can injure the rectum. So a lot of people have been very hesitant to use those devices.
Perfect. So in terms of the long term, I'm going to say Dr. Derderian operate on these cases and then he sends to our multidisciplinary clinic. Most of these patients suffers from neurogenic bladder. They end up needing intermittent catheterization and fecal incontinence, needing enemas to stay clean in the underwear, especially with such a large sacrococcygeal teratoma. So it's absolutely extremely important to continue to follow these patients and determine what's their bowel and bladder status. So those patients also need urodynamics to make sure we protect the kidneys in case they develop neurogenic bladder.
I just want to say something really quickly, that we don't just see cosmetic aspect, we also see the functional aspect, and that's why we do this type of surgical procedure, because with this we avoid the anus displacement. That is the most important thing that I want to share in this
Yes,
case.
and I have seen patients with the anus way up in the back that it's actually very hard for them to even sit in the toilet after those operations. So I honestly think your result was fabulous.
Thank you.
And Anna, the other thing I would say, thinking about this case, we've seen a number of them that have had spinal cord involvement, so like a meningeal component to it. And so that's one of the reasons that we get MRIs preoperatively on these. It clearly didn't look like that on the CT scan, but occasionally we like to know before we get into any dura in the operating room. So MRI has been valuable for us preoperatively.
Thank you.
Thank you very much. We're going to now proceed to the second case that will also be presented by Dr. Ana Cristina Castellanos from Mexico City.
Okay, so our second case involves a 4-year-old baby from Puebla. At birth, he was diagnosed with esophageal atresia, duodenal membrane, anorectal malformation, and congenital adrenal hyperplasia. On the second day of life, he underwent an esophagoplasty with fistula closure. At 1 month of age, a Kimura duodenoplasty and colostomy were performed. A distal colostogram later revealed a high rectourinary fistula, and the patient was referred to our institution for further management. We inquire where the child passed urine through the distal stomach. The mother denied this and report urination only through the penis. On the physical examination, we find a colostomy with distal fistula, flat bottom, absent myelin growth, and absent anus. We complete the assessment to rule out other Bacter anomalies, and we didn't find cardiac, renal, vertebral, or either limbs anomalies. As part of the preoperative evaluation, we repeated the distal colostogram to determine where was the fistula and the length of the distal segment. We are presenting a video of the complete procedure. Here we can see a short distal bowel. So what type of fistula does the patient have?
Let's see what people answered.
Okay.
Majority rectal bladder neck fistula.
Okay, so the next question, it would be, what surgical approach would you choose? Okay, so we are agree with you. Okay, so we opted for a mixed surgical approach. We began with a posterior sagittal approach, and we proceed with distal rectal dissection. Once the rectum was fully mobilized up to the peritoneal reflection, we continue with an open abdominal approach due to the patient history of previous abdominal surgery. During the abdominal phase, we identified the rectum, as you can see in the image, the bladder, and we also find the rectobladder neck fistula. In the second image, you can see with these the arrows where was the fistula, and it was dissected, ligated, and divided, as you can see in the image. So the distal segment of the colostomy was really short, and we could not be lowered adequately due to the limitation of the vascularity mobility. So that's why we decide to mobilize the distal stoma. We look for the vessels, as you can see in the video, and then we rotate it about 180 degrees. We ligate a few arcade vessels to gain sufficient length, and this was achieved without compromising vascularity or twisting the mesentery. After we have a good length, we start the anoplasty, and then we reconfigure the distal colostomy. And the patient is start oral intake after recovering from anesthesia, and he completed antibiotic regimen, and he was discharged on postoperative day 7. Thank you.
Thank you very much, Dr. Castellano. I think this case is like a pediatric surgery book, right? The patient had so many anomalies, so many approaches. That's the dream of a fellow, to have a patient like that. But the points that we have to learn in this case is the importance of doing the right colostomy. If we do a very distal colostomy, we make the pull-through very hard, and in some cases, impossible, because in some cases, we cannot bring this distal stoma down. So I just want to emphasize the importance of doing a true descending colostomy, so we have enough pull-through for, we have enough length for the pull-through. In terms of laparoscopy or laparotomy, we say it depends on your experience. But in this case, when you don't have enough bowel to bring down without taking the mucus fistula down, you will end up having to open the abdomen anyway. And as you shown in the video where you have the mucus fistula in your hand and where the fistula to the bladder neck was, then you have to really see that blood supply to see what is the vessel that is feeding this segment, which vessel I can ligate, or which avascular segments I can ligate to decide if this segment will come down. And then the options that you have. Sometimes we have to bring it down and leave it as a Hartmann pouch. Sometimes we can just move the mucus fistula a little lower in the abdomen. And in some cases, we actually have to close the colostomy there, because if we leave a Hartmann pouch too low, it will be a very hard colostomy closure in the future. So I think this case they are challenging, but it emphasizes the importance of making the right colostomy at the beginning. Now, there was a question about PSARP or not PSARP. We always prefer to open. We don't like the trocar blind. We have seen injuries pushing the trocar from the perineum. We have seen injuries to the ureter, to vas deferens, to the bladder, to the urethra. So whatever works for you, it's your preference, but we still recommend opening. Now, if you're going to open before or after, I don't think it makes a difference. You will have to create that communication from the perineum to the abdomen. Do you want to comment?
The bladder neck fistulas also can be treated without putting the patient in prone position. Once you know that the patient needs a laparotomy or a laparoscopy, we do something called total body preparation. We prepare the skin of the baby from the chest all the way down and put the patient in supine position, lying down on the back. Then we go through the abdomen, mobilize the fistula, and then you just lift the legs up and we expose the perineum. We put a pillow below the body of the baby, and then we just make an incision and bring the rectum that we already mobilized through the abdomen. I'm happy to see that you were able to manage very well the blood supply of the intestine, and something that you do mainly under direct vision, not so much through laparoscopy.
Any other questions or comments from the audience? I think we answered all the questions. So thank you very much, Dr. Castellanos, for another interesting case. Just reminding everyone, a patient with a rectal bladder neck fistula has only 15% chance of bowel control. So this is a patient that actually has a good sacrum. So he may be in that category that has bowel control, but it needs to be followed. And our recommendation is if at 3 years of age, the patient is unable to be toilet trained, to start the patient on rectal enemas. Congratulations.
And I have one question. Was the esophageal atresia and the duodenal atresia operated also at your institution, or
No,
was operated in another place?
he was operated in another place.
But is he doing well from that point of view? Esophagus and duodenum is well repaired?
Yeah. Because he doesn't have problems right now about that.
Okay.
Wonderful. Thank you very much. So the next case I'll be presenting, unfortunately, the presented had an emergency and couldn't be here today, but he has discussed with me and Dr. De La Torre, so I will present and I'll ask Dr. De La Torre and Dr. Peña to discuss. This is a presentation from Kosovo. So are you seeing my slides as a full presentation?
Yes, it looks perfect.
Perfect. So this is a complication after a Swenson operation for Hirschsprung disease. This is a male patient that was diagnosed with Hirschsprung disease. While the patient was waiting for the operation, he suffered from intestinal perforation and received a descending colostomy with a Hartmann pouch. Then he underwent a Swenson pull-through procedure with post-operative gangrene of the distal 10 centimeters of the pull-through. He had an emergency resection of the gangrene bowel and creation of an end colostomy. Then the patient was reoperated 2 months later after this complication with a posterior sagittal approach, coloanal anastomosis, and the creation of an ileostomy. He underwent dilations of the anus, and after 2 months, the ileostomy was closed. 10 days after the ileostomy was closed, he started with leakage through the P-SARP incision and developed an enterocutaneous fistula at the site of the posterior sagittal incision and at the umbilical region. So this is the image of the MRI that we can just see a dilated colon. And this one, what concerned me was this area posterior to the rectum that we see that there seems to be a collection. And these are the clinical pictures. We can see some of the spots where there was drainage. Here you can see more. And that's the abdomen of the patient. And the question that the surgeon had was what to do next. So Dr. De La Torre, do you want to comment?
Yes. So we don't know many things about this case because I request some questions to this doctor, but he never answered. He planned to do, he proposed to do 2 different options. One was to do an open abdomen through the median incision and evaluate the distal portion of the neorectum, which is the transverse colon. To me, it's a very short segment. The residual colon is very short. Then he wants to close the fistula, communicating near the belly button, removing the distal 5-10 centimeters of the distal colon, so the neorectum, which is in the pelvis. And then together with the coloincisional fistula, creating the enterocutaneous-like stoma, which is a fistula, and then bring a new colon down for a new, let's say, for a new pull-through. And he said a new colorectal anastomosis. Finish the operation having 10 centimeters above the anastomosis and create a Hartmann-type colostomy, and then create another stoma, and 6 months later close the colostomy. That's the option 1. The option 2 that he wants trying to do is, again, through an open abdomen. I understand it's like a laparotomy. Evaluate the distal portion, close the fistula, the colocutaneous fistula that you already see in the picture, and then close the fistula in the belly button. So this patient is having 2 fistulas, to understand. One, the patient is having leakage, poop leakage from the belly button. He's having leakage from a fistula from the sagittal approach, and almost nothing from the rectum. So my suggestion was, when I replied to this long email and this image, I said, first, we never use posterior sagittal approach to do a pull-through in patient with Hirschsprung. Remember, the patient with Hirschsprung, they have a hypertonic or a high pressure zone in the anal canal. If you want to do a sagittal approach in a patient with Hirschsprung, most probably you are not going to be successful. Most probably you are going to have these type of complications. The hiscence of the sagittal or fistulas from the rectum to the neorectum to the incision in the sagittal approach. So my suggestion was to wait and then create like a Swenson resection of everything, because for sure everything in the pelvis should be a disaster. Most probably, this patient has now severe fibrosis in the pelvis, like a cement in this patient. And sometimes this patient ended up just with clean out of the pelvis, removing all this ischemic and infected tissue, which is really not a good bowel for another pull-through. And then because the patient has a very short segment, residual segment of the colon, I would suggest to do an end colostomy. To do a pull-through in this patient is going to be challenging. We are not going to guarantee any bowel control. This patient is going to be fecal incontinent. And with all these operations, it's going to be very, very, very difficult to manage the the fecal incontinence. We can try, the doctor can try to do a new pull-through. And I suggest if you want to do a new pull-through, you need to leave an ileostomy. And then 6 months after that, reassess the case and consider to close the ileostomy. So this is to me, based on the description that he sent and some files that we don't show in this presentation, sounds like it was a rectosigmoid aganglionosis, and now the patient ended up just with 10 centimeters of residual healthy colon, but as you can see in the MRI, is very, very dilated. That was my comment to this colleague.
Thank you, Dr. De La Torre. I think it's a very sad case, as Dr. De La Torre mentioned, because it was a patient that was probably born with a good prognosis, Hirschsprung, and I think the chances that this patient will even have a pull-through is very low. So I think when you have a complication, I'm very interested in the concept of rescuing the patient. You cannot continue in the path of disaster after disaster. And one of the things that help a patient like that, the patient is currently infected. So the patient needs the cleaning of this distal colon, because we could see that it's filled with stool, and a stoma, and wait until all this inflammatory process is gone. Then we're going to study the patient and see if it's how much colon this patient has left and if it's even viable a reoperation. And worst case scenario, this patient will end up with a permanent ileostomy. Do you want to comment?
Yes. Already Dr. De La Torre mentioned about the contraindication of the posterior sagittal approach in Hirschsprung disease. At a time when I was beginning operating patients for anorectal malformation using the posterior sagittal approach, I became extremely enthusiastic about the approach. And I remember that I operated on a patient with Hirschsprung disease, and sure enough, the patient developed a fistula. In retrospect, it was an error to do that, the posterior sagittal approach in a patient that we are making an anastomosis proximal to the sphincter. So that anastomosis is under a little pressure. And if you have a sagittal incision in addition, that's an invitation to develop a fistula. So we never use the posterior sagittal approach. Occasionally, we use the posterior sagittal in very complicated cases where you need to see exactly what's happening there, but not that we don't talk about using posterior sagittal for Hirschsprung disease. Now, when in cases like this, if you are going to present a case with our colleagues, my suggestion is that you make adequate diagrams because it's very difficult for us from here to try to imagine what's the current anatomy of the patient. So if we want to know how is the anal canal, and we want to know the details of the anatomic findings, and only by knowing exactly the anatomy, somebody could recommend something. And of course, I emphasize, like my colleagues did, that try not to reoperate patients on an inflammatory state when the patient is just recovering from an infection, when there is a lot of infection. Wait until everything is calmed down, and then reevaluate the patient and make a master plan.
Yeah, so I think in this case, if the patient was in front of me, I would have done now, clean the colon, ileostomy, mucus fistula, wait, and then study from the mucus fistula to see how much colon we have and see if it's even possible and a pull through, or if the patient will end up with an end ileostomy. Any other questions? If not, we're gonna go to the last case that it's gonna also be presented by me. So this is a male patient that was born at 35 weeks gestational age and had failed to pass meconium in the first 2 days of life. So the first question, what would you do first? Rectal irrigation, rectal biopsy, contrast enema, or I don't know. Everybody can vote. And let's see what's the answer. Very good. This is a very well-trained group. So you lose nothing by doing a rectal irrigation. So my advice would be do a rectal irrigation, then do the contrast enema, do another irrigation, then do the rectal biopsy. Next slide. 1 second. So this is the X-ray, and you can see it looks like a distal obstruction. We see a normal sacrum, and that's the contrast enema that was done. So I'm gonna pass the images slowly. And I'm gonna say, even now, in retrospect, and knowing that this patient has Hirschsprung, I would say this is not a classic contrast enema that I can look and say, yes, this is Hirschsprung. I would say this is an equivocal one. Can be, cannot be. So the rectal biopsy was taken and it confirmed Hirschsprung disease. The patient was discharged home on rectal irrigations, and he underwent a laparoscopic assisted Soave pull-through at 4 months of age. He was referred to us at 20 months old because he was dependent on rectal irrigation. The family could never stop rectal irrigation. He would not stool spontaneously. So what would you do with this story? Rectal examination under anesthesia, full thickness rectal biopsy, contrast enema, or all of the above? Everybody can vote. And very good, all of the above. That's exactly what we did. So this is the contrast enema, and just by looking at the contrast enema, you can see that it looks like a colon that it's been suffering from enterocolitis. But you see an entire dilation, you don't see just one aspect. But when we looked, I didn't put here and I apologize, when we look at the abdominal x-rays, he always has gas in this area here. So we did a rectal examination under anesthesia. There was no stricture. There was, the anal canal was preserved. We did a rectal biopsy, and the rectal biopsy was normal. Had ganglion cells, no hypertrophic nerves. So we tried first, whenever a patient comes to us with symptoms of enterocolitis, we put them in a protocol of rectal irrigation. So the first month, 3 rectal irrigations a day with flagyl 3 times a day. Then we're going to slowly try to increase laxatives and decrease irrigations to see if the patient can stool spontaneously. So we tried, but the patient could not increase the dose of laxative. He would start vomiting, not stooling, and had to go back to irrigations. Then we said, well, let's try to see if he tolerates enemas, if we can clean him with enemas, because at least it would be better for the family doing once a day than 3 times a day irrigations. He failed enemas. We tried enemas even in clinic. We would put the fluid in, nothing would come out. He would not empty without irrigations. We had to do irrigations again. So what would you do next? Offer reoperation or try Botox? Let's see what people voted. Everybody would try Botox. Okay, I'm gonna say I am not a fan of reoperation nor a fan of Botox, but I said, let's try Botox because I don't have anatomical explanation for why he's not emptying, right? There was no stricture, there was no twist, there is no. So this is a video. Let's see if I can move this so I can click. So Dr. De La Torre is helping me, and you can see we have the Lone Star, and we actually inject in the anal canal, very superficial. We create that little bubble, and then we massage. And I'm gonna ask Dr. De La Torre to comment on the Botox injection, but we do in this quadrant, this quadrant, this quadrant, and this quadrant. So the patient did well for the first 2 months, and then he came for follow-up with this abdominal radiograph, where you can see he is filled with stool. We tried again laxatives, and he did not respond. So we went back to rectal irrigations, and we decided to schedule him for a reoperation due to persistent obstructive symptoms that were not responding to medical maneuvers. And those, in my opinion, are the challenging cases because we are going to propose a resection to try to make the patient manageable, to try to avoid the need for rectal irrigations. So here you can see the patient is in prone position, and we use the Lone Star retractor, and here you can see that this is the anal canal. Now we're going to advance the hook and protect the anal canal, and we're going to start our dissection around here, 1 centimeter. And in this case, we did transanal and laparotomy, and we resect 15 centimeters of the distal bowel. Intraoperatively, there was no difference that I could see. This is a sick bowel, this is a healthy bowel. So we decide to just mobilize splenic flexure and bring the segment down. And I will bring back this patient to see if he has improved or not as a follow-up. So our routine is to keep the patient NPO on TPN for 7 days. We will send the patient home on rectal irrigations for 3 months. So the first month, 3 times a day with flagyl 3 times a day. Second month, 2 times a day. 1 month, last month, 1 time a day. And at that time, we need to see if the patient is stooling spontaneously. So in 4 months, I should give you an update on how the patient is doing. I'm going to ask Dr. De La Torre to comment on the Botox injection because I feel that this is an area of a lot of controversy. So Dr. De La Torre, can you comment?
Yes. So I don't know what happened with this patient because this is Andrea's patient. The Botox is a toxin that produces a chemodenervation of any muscle. Could be smooth muscle or skeletal muscle. The idea to use Botox in patients with Hirschsprung is to produce a chemodenervation of the all the circumference of the anal canal. Why? Because we know that the anal canal already is like a high pressure zone. The anal canal never is going to improve the motility of the colon, never, never, never. So the idea to use Botox is not going to say, okay, now with Botox, the patient is going to poop on its own and it's done. No, the idea to use Botox is just like an adjuvant, like an other resource to manage the patients with irrigations. So when I use Botox, I continue the irrigations and I start to wean the irrigations if the patient start passing gas or bowel movements between irrigations. He's doing 3 times a day. Now we're doing 2 times a day. Now once a day. Some patients, we can transition from irrigations to enemas because the patient with this type of obstruction, when you try to do enemas, they don't tolerate the enemas. They become very sick. They have nausea, vomiting, and it's not quality of life. And in fact, they don't have bowel movements. So sometimes we can transition from 2, 3 irrigations a day to 1 enema per day using the Botox. Some patients with Botox, they start to pass gas and poop on his own, and the parents stop the irrigations and enemas, and then they use laxatives, nothing like that. So how sick is the colon? Is the response to the Botox. If you apply the adequate amount of Botox in the adequate place, for sure you are going to denervate the anal canal. But this is not the treatment. This is not the treatment for these obstructive symptoms. This is just an adjuvant for these patients. That's my comment.
Thank you very much, Dr. De La Torre. And Dr. Peña, there is a question about intestinal neuronal dysplasia. Do you want to comment that?
That person asked me personally?
No, just said, could this be intestinal neuronal dysplasia for everybody?
So we don't believe in the existence of that condition. We went through that discussion many times, and I even went to meet the creator of that entity, but we don't believe in the existence of that condition. And we could communicate separately. You can send me emails. I would be happy to discuss that. We simply it's an invention that has no scientific basis, so we don't use that term, and we don't believe in the existence of that.
So there is a question, would you do the pull-through if the colon is extremely dilated? I think if you meet a patient with an extremely dilated colon that needs a redo pull-through, a stoma is a wise decision to decrease the size of that colon. Any other questions? So I
have a question for you.
For me.
You did the pull-through, and did you find the location of the original anastomosis that the surgeons performed?
No, I did not.
So how did you know perhaps the patient never had Hirschsprung?
No, the patient had Hirschsprung. I've seen the specimen. The patient was operated by someone that I know. So the patient had Hirschsprung for sure. And it had a ganglionic bowel, but the surgery was done well in the sense that there was no twist, there was no stricture, the distal pull-through had ganglion cells, so the surgery was done correctly, and the patient was still not doing well.
Patient was not operated in this institution?
No.
And they send you the pathology report?
Yes.
How can you explain that there is no signs of where the location of the anastomosis.
Well, sometimes you do an anastomosis well enough that you don't see where it is.
It's called the surgeon and congratulate him for some. I never seen that.
But you have seen patients that have received a good operation and don't do well.
Of course.
That's the case. Well, thank you everybody for joining us today. Again, we had pediatric surgeons from Malaysia, Yemen, Mexico, Bangladesh, Bahrain, Spain, Vietnam, Qatar, Saudi Arabia, Sri Lanka, Germany, Brazil, Iraq, Libya, Czech Republic, Romania, Turkey, Thailand, Japan, Peru, Philippines, Tanzania. I think I got everyone. Yes, Colombia. Okay, we'll see you next time. Thank you very much.